Hello, I'm Dr. Joel Krimmer, Fat Family Professor of Medicine at Albany Medical College and Director of Research at the Center for Rheumatology in Albany, New York, and CMO of Corona. I'd like to mention that this program will include a discussion of off-label treatment options. In addition, this program will include a discussion of investigational agents, devices, or diagnostics not approved by the FDA for use in the United States. Before I begin my discussion, please take a moment to test your knowledge on this topic by answering a few questions. You will have another chance to answer these questions at the end of the activity to see what you've learned. Let's start with a statement on the pathogenesis of rheumatoid arthritis. Of course, it's not completely understood. An external event triggers an autoimmune reaction leading to synovial hypertrophy, joint inflammation, and possibly extra-articular manifestations. There is indeed a genetic susceptibility, which is strongly believed to be a factor. There are many different cell types engaged with the pathology, the immunopathology of this disease. There's CD4 positive T cells, mononuclear phagocytes, fibroblasts, osteoclasts, neutrophils, which play a major role in the immunopathology of this disease. B cells also play a major role producing autoantibodies, which we know in many circumstances drive the disease. There are also numerous inflammatory mediators in the circulation and in the synovium, including pro-inflammatory cytokines and chemokines, which are known to play a large role in rheumatoid arthritis. Of course, some of these include TNF-alpha, interleukin-1, 6, and 17, GM-CSF, long name granulocyte macrophage colony stimulating factor, and also downstream mediators. Biologic drugs have shown a dramatic benefit in neutralizing cytokines and inhibiting inflammation. TNF inhibitors, IL-1 receptor antagonism, co-stimulatory blockade, B-cell depletion, and IL-6 antagonism have all been efficacious. Lack of effectiveness in adverse events in some patients have triggered this search for additional targets. Our agenda today in this lecture will be to explore JAK inhibitors, both approved and in development, IL-6 inhibitors, and GM-CSF receptor targets. So let's start with the JAK inhibitors. The JAK-STAT pathway is a selective target for therapeutic intervention in rheumatoid arthritis. JAK-STAT proteins play key roles in cytokine-induced signal transduction. There are 4 JAK proteins, very cleverly named JAK1, 2, and 3, and also tyrosine kinase 2, TYK2, and 7 STAT proteins are known. Now, the JAKs are associated with various cytokine receptors, which are activated when a cytokine binds to the cognate receptor. And we'll show you a figure of how this works. JAK1 interacts with numerous cytokines through the common gamma chain receptor subunit and the GP130 subunit, the ligands of which are IL-2, 4, 7, 9, 15, 21, through the gamma chain receptor, IL-6, 11, 27, and 31, through the GP130 receptor, and interferon alpha, beta, and gamma. Cytokine-induced signaling will occur through JAK2, which interacts with cytokines through the GP130 receptor family, and with hormone receptors for erythropoietin, thrombopoietin, prolactin, and growth hormone. JAK3 is associated with the common gamma chain cytokines. TYK2 is seen through the IL-12 receptor and in interferon alpha and beta signaling. This graphic shows a cartoon of a GP130 unit with a cytokine. This causes a transformational change with phosphorylation of the intracellular JAKs, the Janus kinases, leading to subsequent phosphorylation and a transformational change in the STAT pathway, tyrosine kinase moieties, which is depicted here. Once the STATs are activated, they go through the nuclear pore for transcription of all kinds of downstream pro-inflammatory mediators, which is depicted here at the nucleus. And there is, in fact, a feedback pathway, which is complex and which we are not describing in detail with this graphic. Let's move on to IL-6 inhibitors. IL-6, of course, is a cytokine with effects on numerous cell types, including those involved in the pathogenesis of rheumatoid arthritis. And it is certainly another target of therapy. IL-6 is found in the synovium and serum of RA patients. We know it's engaged with activation of synovial fibroblasts, activated macrophages, and lymphocytes. IL-6 also regulates RA and is associated with a variety of systemic symptoms. It does indeed initiate the acute phase response, inducing hepatic synthesis of C-reactive protein, or CRP, serum amyloid, haptoglobin, and fibrinogen. These are the classic acute phase reactants. It also activates vascular endothelial cells, upregulating expression of certain chemokines and adhesion molecules, facilitating leukocyte recruitment directly to the sites of inflammation. This graphic shows some of the biological effects of IL-6 on the liver, where acute phase responses are produced, as we mentioned, and on many other cell types which are actually driven by the production of IL-6. So IL-6 does more than just produce CRP and elevate ESR via fibrinogen. It activates a variety of cell types, and we know from experience that IL-6 inhibition is a very potent means of inhibiting this disease. So continuing, IL-6 does regulate RA symptoms. It does induce B-cell differentiation, which may lead to hypergammaglobulinemia and production of autoantibodies such as rheumatoid factor and other autoantibodies, including citrullination of peptides and autoantibodies to these peptides. It prompts synovial fibroblast differentiation and osteoclast activation. And we know it's active in bone resorption. And it contributes to the pannus formation and cartilage and bone destruction. So here's another graphic of the IL-6 associated inflammatory pathways. And you see that IL-6 is really a central cytokine affecting a variety of cell types. And those cell types, in turn, when activated, lead to mediation of the inflammatory cascade and lots of other activities, including production of VEGF from synoviocytes and activation of rank ligand and joint destruction. IL-6, in addition, correlates with disease activity. That is, elevated levels of IL-6 correlate with disease activity parameters, specifically duration of morning stiffness, a Ritchie articular index, and treatment with methotrexate decreases levels of IL-6 and improves measures of disease activity. GM-CSF, granulocyte macrophage colony stimulating factor, can exacerbate rheumatoid arthritis. GM-CSF regulates myeloid cells involved in innate immunity, including neutrophils and macrophages. Neutrophils secrete pro-inflammatory cytokines, including IL-1, 8, TGF-beta, and alpha, and TNF-alpha. Activated macrophages release pro-inflammatory cytokines, and TNF-alpha, IL-6, and IL-1, and various chemokines, all downstream from GM-CSF activation. Let's talk about the role of GM-CSF in rheumatoid arthritis. We know that macrophage infiltration is prominent in the rheumatoid synovium, in early RA, and even in established rheumatoid arthritis. High titers of GM-CSF are found in moderate to severe RA. Increased levels of GM-CSF are found in the plasma and in the synovium, and this is thought to play an important role in both differentiation and function of macrophages and neutrophils. Here's a graphic which shows the many ways in which GM-CSF can stoke up the immune process from proximal to distal, starting with production of chemokines and growth factors from an activated macrophage, proliferation of these macrophages with downstream proliferation and release of several mediators which could contribute to the immune inflammatory milieu, which certainly contributes to rheumatoid synovium. Let's move on and talk about JAK inhibitors. JAK stands for Janus kinase. One of the JAK inhibitors that's been approved and marketed is the drug tofacitinib. Tofa is a small molecule, an oral agent that suppresses JAK1 and 3, and to a lesser extent JAK2 in patients with RA. It is approved to treat adults with moderate to severe rheumatoid arthritis who have had an inadequate response or who are intolerant to methotrexate. It can be used as monotherapy or in combination with methotrexate. So in a 12-month study called STANDARD, this was a randomized, double-blind, controlled, multi-center phase 3 trial produced by Ron van Vellenhoven and all published in the New England Journal in 2012. Tofacitinib 5 milligrams BID or 10 milligrams BID was compared with adalimumab 40 milligrams sub-Q every other week, or placebo added to background methotrexate. So the standard endpoints are depicted. Primary endpoints, ACR20 response, DAS28 ESR less than 2.6, which is a definition of remission for DAS in month 6. HAQ-DI, standard patient-reported outcome, improvement at 3 months. So standard efficacy findings. At 6 months, ACR20 response rates were higher among patients receiving 5 milligrams, 51.5%, or 10 milligrams of tofacitinib BID, now it's 52.6%, than those receiving placebo, where it was 28.3%. ACR20 response rates were also higher among those receiving adalimumab at 47.2% compared with placebo. And the p-values were highly significant at 3 decimal points, p less than 0.001 for all comparisons. These are the standard safety findings, and you can see from left to right, placebo, tofa 5, 10, and adalimumab. What I pay careful attention to is not necessarily all adverse events, but serious adverse events and serious infectious events. And you see from left to right, 5 and 10, that we're talking about 5.9 and 5% compared to 2.5%. Denominators are about 200, as you see. Patients with serious infections, 1.5, 2.0, and 0. We should be cautioned that when looking at sparse adverse events, it becomes somewhat problematic unless the n in the denominator is quite large. The numbers are, however, quite small, and they should speak for themselves. Another JAK which is in development is baricitinib. The investigational oral small molecule baricitinib is primarily active against JAK1 and 2. 301 patients were randomized to receive once daily doses of 1, 2, 4, or 8 milligrams baricitinib or placebo for 12 weeks. Patients were assigned to 2, 4, and 8 milligram baricitinib and a continued blinded treatment for an additional 12 weeks. and this was published by Ed Keystone et al. In ARD. So patients assigned to placebo or 1 milligram baricitinib were reassigned to 2 milligrams BID or 4 milligrams once daily baricitinib for weeks 12 to 24. That is, they had an escape if they did not respond. The primary endpoint was the proportion of patients in the combined 4 and 8 milligram groups achieving an ACR 20 response versus placebo at week 12. Efficacy findings: more patients in the combined baricitinib 4 and 8 milligram groups did achieve an ACR 20 response at week 12 compared with placebo, and in fact that was 76% for an ACR 20 versus 41%, and that p-value was highly significant at 0.001. Significant differences were also seen at week 12 in patients achieving ACR 50 and 70, and remission is measured by DAS28, CDAI, and SDAI. Patients receiving 2, 4, or 8 milligram baricitinib maintained or improved in all measures through week 24. Summary of safety findings: there were a similar proportion of patients who experienced at least one AE in the placebo and baricitinib groups. 2 patients receiving baricitinib developed serious infections. 4 patients receiving baricitinib developed serious adverse events. And 4 patients receiving baricitinib discontinued the study due to an adverse event. Let's move on to filgotinib, also known as GLPG0634. Filgotinib is a JAK1/2 inhibitor, and in isolated kinase assays shows much better JAK1 selectivity in whole blood assays. So let's talk about 2 phase 2b 24-week dose-finding studies, which were completed, and we are in fact awaiting results at the time of this taping. Darwin 1 was a study evaluating filgotinib plus methotrexate in 595 patients in doses of 50, 100, and 200 milligrams daily, and 25, 50, and 100 milligrams twice daily. Darwin 2 is evaluating filgotinib monotherapy in 280 patients in dosages of 50, 100, and 200 milligrams daily. Another interesting JAK inhibitor is ABT494. This is a so-called second-generation inhibitor of Janus kinase pathways. There are 2 phase 2 studies which are currently underway examining ABT494. One of these studies evaluates the drug in 4 doses, twice daily plus methotrexate. Participants are JAK inhibitor naive and have failed TNF inhibitor therapy, TNF failures. There are 2 evaluating ABT494 plus methotrexate in patients who have had an inadequate response to methotrexate alone. So your standard models, methotrexate failures, TNF failures. Finally, let's move on to IL-6 inhibitors. Tocilizumab. Tocilizumab is, of course, approved and indicated for adults with moderate to severe active rheumatoid arthritis who have had an inadequate response to 1 or more DMARDs. It can be given, as we know, as an IV infusion or a subcutaneous injection. A 2015 retrospective analysis assessed the efficacy of tocilizumab and TNF inhibitor alone or in combination with DMARDs. There were 1,603 patients with an incomplete response to previous treatment with DMARDs and or TNF inhibitors who were managed in routine clinical practice who were entered into this trial. The findings were that there were significantly more patients who achieved remission, defined as a DAS28 less than 2.6, in the tocilizumab groups compared with the corresponding TNF inhibitor groups, and that p-value was 0.001 for all comparisons. More patients achieved moderate to good response using the EULAR criteria in the tocilizumab treatment groups, that is 79 to 85%, compared with the TNF inhibitor treatment groups, where it was 65 to 81%. There were also a greater improvement in PROs, patient-reported outcomes, which were seen in the TOSI group compared with the TNF inhibitor group. Sarilumab is an IL-6 inhibitor being developed in phase 2 dose-ranging studies. 306 patients with active RA, despite methotrexate, were indeed randomly assigned to placebo or one of 5 sub-Q dosing regimens of sarilumab. The findings were that there were improved signs and symptoms of RA over a 12-week period. The safety profile was similar to reports with other IL-6 inhibitors. Sarilumab, 150 milligrams and 200 milligrams every 2 weeks, had the most favorable efficacy, safety, and dosing convenience and are being further evaluated in phase 3. The drug mavrilimumab is a human monoclonal antibody to GM-CSF receptor alpha. It is a competitive antagonist of GM-CSF signaling. In a phase 2 clinical trial, 239 patients receiving sub-Q MAV at 4 different doses or placebo administered every other week for 12 weeks plus background methotrexate was studied, the primary endpoint being the proportion of patients achieving a greater than 1.2 decrease from baseline in DAS28 CRP at week 12. The findings, as published by Gerd Burmeister et al., 55% of MAV-treated subjects met the primary endpoint versus 34.7% at week 12 with a p-value of 0.003. A biomarker-based disease activity score showed a dose-dependent decrease at week 12, indicating suppression of disease-related biological pathways. Safety, adverse events were generally mild or moderate. There was no significant hypersensitivity reaction were seen. There was no serious or opportunistic infections. And importantly, there were no changes in pulmonary function in this inhibitor of macrophages, including hypothetically pulmonary macrophages. So let's wrap by trying to consider how we might utilize these new treatments. 2 of them are on the marketplace, tofacitinib, tocilizumab. Very different mechanisms, although there is perhaps some overlap with tofacitinib, the oral agent, JAK inhibitor, which we know at least partially inhibits IL-6. Both of these are viewed by myself as very potent agents. I've been privileged to participate in clinical trials of both of these agents. I use them both in the clinic, and I think they have an important role in our therapeutic armamentarium. We have emerging treatments, several JAKs actually, baricitinib, ABT-494, filgotinib, 3 different JAK inhibitors. The JAK pathway is actually quite complex, and the potential efficacy and toxicity will vary depending upon which JAKs are inhibited and to which extent. So I think that we don't know exactly how that deck will be shuffled, and I suspect we'll all be using JAKs routinely, if we're not now, in coming years, and we'll develop our own experience with these agents, which is always what we as clinicians go by, and hopefully we read the literature as well. IL-6 inhibition, we reviewed with tocilizumab. There are other agents, several of which are in the marketplace. We mentioned one, sarilumab, which shows significant promise. And lastly, an entirely different unique mechanism, that's GM-CSF, granulocyte macrophage colony stimulating factor, which I think we must say through phase 2 shows promising results and a refreshing minimal toxicity to date. So I'll stop there. I'm encouraged and gratified that my difficult patients with RA do indeed have a lot of options presently and will have a lot of options going forward. I think for all of us, we need to read the literature, familiarize ourselves with the potential benefit and side effects of all of these agents so we can be good advisors to our patients and help them in a dialogue with us make the right decisions about what treatments they should receive. Thank you for participating in this activity. Please click on the Earn CME Credit link to revisit the questions presented at the beginning of the activity and see what you've learned. The CME post-test and evaluation will follow. Thanks again.